Well, thank you, everyone, and we appreciate you joining us here today for this speaker series session, Empower Your Lungs, the Roles of Vaccines in Respiratory Health, with our presenter, Dr. Samir Gupta. We'll just give one moment for other people to arrive before we officially get started. As people are arriving, we're going to begin shortly. Dr. Gupta is here, and we will begin the session in just a moment. Thank you for joining us. So I think in the interest of time, we have a lot of ground to cover in this session today. So I think we'll get started, and we're excited to get started. I hope everyone can hear me all right. If there are any technical issues at all, just drop a note in the chat, and we will deal with them that way. But in the meantime, want to make sure that we welcome everyone. This is an issue that is of interest to everyone across the population, I'm sure, but especially for those who are living with asthma. We know that there are 4.6 million Canadians that are living with asthma across the country, and that people with asthma and other respiratory health conditions have a higher risk of complications from vaccine-preventable illnesses. So that's really what this webinar today is all about. It's about exploring some of these vaccine-preventable illnesses, the risks for people with asthma, and tips in order to access vaccines and help you as patients and caregivers to make informed choices. So my name is Jeff Beach, and I'm the President and CEO of Asthma Canada. Before we dive in, just a couple of quick housekeeping items. This webinar is being recorded. It will be available on our website soon, and we would ask that when it is, if you would kindly help us share it. We want to get this messaging out to as many people as possible across the country. So please look for that and share it widely. All of the attendees are muted just to avoid any distractions and background noises when we have a group of this size. But please type into the Zoom Q&A feature any questions that you may have. If you have any issues, reach out through the chat. And we'll try to make sure that we save some time at the end for questions that are submitted today, as well as those that came in advance of the session. We thank those that did submit questions in advance. If you could advance to the next slide, please. So we do want to take a moment to acknowledge that this webinar has been made possible through the Immunization Partnership Fund at the Public Health Agency of Canada. Their support is essential in enabling us to share important information on vaccines and respiratory health with the asthma community. So we thank the Immunization Partnership Fund and our other sponsors and donors for helping to make this possible. Next slide, please. Before we get into our content for today, I'd like to take a moment to acknowledge the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, we do take a moment to acknowledge the importance of the land which we all call home. We recognize that those joining us are doing so from across various lands and territories, and for thousands of years, Indigenous peoples inhabited and cared for these lands and continue to do so today. We're very grateful to have the opportunity to work on this land, and by doing so, give our respect to its first inhabitants. And next slide, please. Just a little bit about Asthma Canada. We are committed to improving the lives of people across Canada that live with asthma and their caregivers. And we really focus our efforts as a registered charitable health organization on providing education and support services, as well as advocacy and research. So we empower people with sessions like today's with our website, asthma.ca, as a credible, accessible source of information. We also do some work in advocacy around clean energy and clean air, and making sure that people across the country have equitable access to the treatment and healthcare that they need to live well. And finally, we invest funds that we raise in research towards our ultimate vision, our goal, which is to find a cure for asthma at some point. And in the meantime, make sure that people have access to effective treatments to control their disease. We are going to ask a couple of poll questions here. I believe there are 4 questions. So we are going to be covering areas, as I mentioned earlier, about vaccines and lung health. And so before we begin, we just have a few questions that we'd like to ask. These are anonymous questions, and we will not be sharing any personal information. I'll just give everyone a moment to respond to those. And while we have the poll questions up, I'm going to take a little bit of that time to introduce our presenter for today. So it is my pleasure to introduce Dr. Samir Gupta, who is a respirologist at St. Michael's Hospital and an associate professor in the Department of Medicine at the University of Toronto. His research interests are in knowledge translation across the spectrum of respiratory illness, with a focus on electronic tools for behavioral change. He also has a specific interest on science communication and is certainly one of the valued experts in the community that we pay attention to as an asthma community. So, Dr. Gupta, we really appreciate you taking time to join us today and to present this information. And I will now turn the control of the floor over to you. Thank you.
Thank you very much, Jeff, for the invitation. Thanks to the Public Health Agency of Canada for funding this series as well. We have a lot of ground to cover, so I'm going to talk a little bit fast. I have a lot of slides, and I'll try to save some time at the end for questions. And I've looked at some of the questions that have come in advance. Thank you for sending those in. I tried my best to touch on most of those. So we're going to be talking about respiratory pathogens, 4 of them, the 4 big ones: influenza, SARS-CoV-2, or the virus that causes COVID, RSV, and strep, as we call it, or the scientific name is Streptococcus pneumoniae, which is a bacteria. All of these are contagious. They're all spread in similar ways by the spread of droplets between people when they cough or sneeze or talk or sing. And we're kind of used to this droplet spread discussion because we heard so much about it during the pandemic. But there's direct transmission and indirect transmission. And direct is sort of droplets that are a little bit larger particles of water that come out that usually don't spread beyond a few meters. And then there are aerosols, which are tinier ones that get suspended in the air, and they can transmit essentially indirectly across large distances. And then there's truly indirect transmission, which is what we call fomites, or inanimate objects that can sometimes harbor the virus or the bacteria for a period of time where you can catch it from the object. So the pattern of spread is pretty similar. And in fact, the pattern of infection is very similar. And so often patients who have a viral illness will come into the office and say, hey, which one do I have? Do I have the flu, or do I have RSV or COVID? And the reality is it's very hard for us clinicians to know that. And this should sort of tell you as a patient too, if you ever suffer from one of these viruses, it's very hard to tell which one you have. If you look at upper respiratory tract infectious symptoms like congestion, sore throat, hoarseness, very similar across the 3 viruses. Lower respiratory tract infectious symptoms also very similar, with the exception of chest pain being less so in RSV, wheezing being less so in COVID. And then what we call systemic symptoms like body aches, fever, fatigue, again, very similar. So it's very difficult to disentangle these viruses from one another in terms of the way they present clinically. We're going to start with influenza, or what we call the flu. This is an important virus. The burden of this virus on our healthcare system annually is 175,000 emergency room visits, more than 12,000 hospital admissions, and more than 3,000 deaths. And it's not just the respiratory system. So we're here talking about asthma today. So of course, any virus, including the flu, is a cause of asthma and COPD exacerbation. But it is also a trigger for other organs to be affected and to be triggered. And that includes triggering heart attacks, also earlier onset heart disease, triggering strokes, worsening kidney disease, and diabetes. So it is a virus that affects systems even outside of the lungs. When you think about risk factors, and we're going to talk about risk factors for every one of these infections, and you'll notice that they're very similar, and they're not surprising. We know that the immune system gets weaker as we get older, and so old age is a risk factor for pretty much all of these infections, but also chronic medical conditions, in this case, asthma being one of them, cardiovascular disease, diabetes, also a weakened immune system if you're on chemo, for example, if you have HIV, environmental factors like folks in long-term care homes or folks who are more frail. All of these folks have worse outcomes when they get this infection. Importantly, that includes asthma. Now, the story with flu and asthma, there has been some debate in the literature around whether you are actually more likely to catch the flu. There's a theory that inflammation caused by asthma might reduce what's called the innate immunity, or the barrier function that these so-called airway epithelial cells play. And those are cells that line our airways, that essentially protect us from anything we breathe in. And so this is debated in the literature, but what's not debated is that if you do get the flu, you have a higher chance of having a more severe, more symptomatic and more problematic infection if you have asthma. And that partly is because any virus, including the flu, might also trigger your asthma. So now you have two problems. You've got the infection and you've got an asthma exacerbation going on. We also know that viral infections trigger and worsen inflammation. And in asthma, they worsen bronchial hyperresponsiveness, or that twitchiness of the airway. So they kind of exaggerate some of the underlying problems that we already face with asthma. So these patients who have flu and asthma end up with a higher risk of ending up in hospital. And the solution to the problem, of course, and why we're here today, is to talk about vaccines. So these are the 5 adult vaccines that are approved in Canada. Just to give you a general sense, we've got a standard dose vaccine that's for anybody, adjuvanted or high dose. These are vaccines. An adjuvanted vaccine basically contains an adjuvant, which is considered an immune booster. It boosts the immune response. High dose is just what it says. It just has a higher dose of the antigens. RIV4 is a recombinant type of vaccine, so a different style of creating the vaccine. And then there's IIV4CC, which is a vaccine that was formed in cell culture as opposed to egg-based. The rest are egg-based. There was a question about people with egg allergy. Actually, the National Advisory Committee on Immunization suggests that even if you have anaphylaxis to egg, you can have any of these egg-based vaccines because there's so little of the egg protein or egg antigen inside the vaccine. But if you have had a bad reaction or are concerned, there's the option of the cell culture vaccine. Now, the 3 that I've highlighted in yellow here are actually the 3 vaccines that are recommended for people who are 65 plus. We talked earlier about with age, the immune system becoming a little bit weaker. So we need these higher doses or these adjuvanted vaccines to really get that adequate immune response in older patients. I'm going to consistently turn to what's called the NACI, or the National Advisory Committee on Immunization, which I mentioned earlier, and talk about their recommendations, because this is really where we look to in terms of our national body that reviews all the evidence and makes recommendations for these vaccines. And generally, they have 2 styles of recommending things. Either they say, this is a strong recommendation, which means we should offer it to all patients, or most patients, almost all patients, let's say. And then they have a discretionary level. Discretionary recommendation may be offered, and that's more of a discussion around what the patient characteristics are and what the patient's preferences are. So keeping in mind, there's sort of 2 levels. For the flu vaccine, it's a strong recommendation that it should be offered annually to anybody who's 6 months and over. So this is, this is really the only one where you're going to have this, where anybody 6 months and over really should be getting this vaccine. Now, they do identify high-risk groups who especially should get the vaccine, but important is, for the starting point, it's saying everyone should get it. Now, the groups that are high risk include people who are at risk of severe disease. Makes sense. And that includes people with cardiac and pulmonary, and I haven't put the whole list here, but I've said cardiac or pulmonary because I want to point out that asthma is explicitly listed as one of those conditions that really should get this vaccine. Of course, people who are at higher risk of transmitting it, so somebody who might be healthy themselves, but living with somebody who has a weak immune system, people who are essential community service workers like healthcare workers, and then people who work with poultry, because we don't want intermixing of the avian influenza with the human influenza A. We have had, as you know, the vaccine changes every year because it changes to match the latest flu that is around. And there's this kind of perception that it's not a very effective vaccine, but this is actually looking at 10 years worth of vaccine effectiveness right before a pandemic. And what you see here is that it does vary. The vaccine effectiveness in any one year is anywhere between 40 to 90%. But by and large, this is a vaccine that is quite effective, and this vaccine will protect. You have 1 year there that I pointed out, 2014-15, which is what we call a mismatch year, which happens rarely, but that's when the vaccine doesn't match the virus that is circulating. And it's a process to figure out what virus will be circulating, but that process involves a little bit of informed guesswork around what's going to happen by the time the virus comes, because the vaccine has to be decided upon and prepared in advance. But as you can see from the graph, we're pretty good at that. And we end up getting a vaccine in most years that is very beneficial and protective. It's not just protective against infections. It's protecting you against bad things happening when you get that infection. And so for people who are 65 plus, who were hospitalized with flu, they had a 61% lower chance of dying in hospital if they had been vaccinated, and a 37% lower chance of ending up in the ICU. They also had a 34% shorter stay in the ICU if they did end up there, and a 24% overall shorter stay in the hospital. So even if you get it, even if you get sick from it, you're going to get less sick from it if you've got the vaccine in you before you get that virus. So what are the benefits overall? It's going to reduce your chances of getting it, reduce how sick you get when you get it, which means less outpatient and emergency room visits, less hospitalizations and ICU visits, less duration and severity of those visits, less heart attacks and strokes. So it goes beyond the respiratory system, as we mentioned. Also less death. That's important. We're saving lives with this vaccine, and it's going to reduce asthma flares specifically for the population we're talking about today. There's some thought that it might reduce the spread of virus. That again is debatable, but that could be another ancillary benefit. You get it, and less people around you get it as a result if you get the vaccine. And the last piece there, which is sort of an interesting outside of the box type of benefit, is a reduction in antibiotic resistance. And there's two mechanisms whereby that might happen. One is that when people get the flu, they often end up in a walk-in or the family doctor. And because it's sometimes hard to distinguish the flu from bacterial infections, they will sometimes end up on antibiotics. They don't need them, but they get them. And those antibiotic prescriptions, ultimately, the more prescriptions, the more the chances of bacterial resistance. The other thing that happens is even if you get the flu, and legitimately it's the flu, because it weakens your immune system and weakens the local defenses in the lungs, you actually have a higher chance of what's called a bacterial superinfection. So actually getting a bacterial infection on top of the flu after you get the flu. And again, that would merit antibiotics. So by getting the vaccine and being less likely to get the flu and a severe flu, ultimately we're going to see less antibiotics prescribed. And that's part of what we call antimicrobial stewardship, which is going to reduce that resistance to those antibiotics long term. In terms of safety, there really are no differences between the adjuvanted vaccine, the standard dose, the recombinant vaccine, and all of these side effects are rare. So there are injection site events, but mostly it's just redness and swelling. What we call grade 3 events, which are more severe events, are extremely rare. Serious adverse events are very rare, and the one that people often talk about or worry about is a neurological side effect called Guillain-Barré syndrome. That is a reversible side effect, and it's extremely rare. So that happens in 1 case per million doses. For context, in the first 6 weeks, if after catching the flu, your chances of getting Guillain-Barré syndrome are 17 out of a million, 17 times higher. So the vaccine is a much lesser evil than getting that virus. And how do we know all this? Well, we know it from post-marketing surveillance. And that's really important because every year, hundreds of millions of these doses are given around the world. And there is this surveillance that happens post-marketing to make sure that we're not seeing any differences or changes in terms of side effects or complications related to the vaccine. And what we find year after year is that these are safe vaccines and the safety profile is stable. It doesn't change. And that's very reassuring. So in summary, this is the time for your flu vaccine. If you haven't done it, fall and winter, now and going forward. It's really recommended for anyone 6 months plus, but especially for folks on this call who have asthma. If you're 65 plus, try to get yourself the high dose or the adjuvanted or the recombinant vaccine. But if it's not available to you, get the standard dose. The standard dose will still help you, just not as much as one of those other ones if you can get them. Let's shift gears, and I'm going to move to the bacterial infection among the 4 pathogens we're going to talk about today, and that is what we call Streptococcus pneumoniae. It's called this because it is a very common cause of pneumonia. If you think about this bacteria, it actually has more than 100 different what we call serotypes or subtypes, and 24 of them have been associated with invasive disease in humans, and those are the ones we protect against with our vaccines. As you see in this pyramid graph here, what we call bacteremic pneumonia, which is pneumonia where bacteria end up in the bloodstream, or non-bacteremic pneumonia, which is more usual pneumonia, comprises almost 100% of the pneumococcal infection. So this is primarily a bacteria that is going to cause pneumonia. Now, I put this up because it tells us a little bit about progress. So what you have is on the x-axis, different age categories, and on the y-axis, incidence of streptococcal disease, invasive disease. So what you see is in the younger groups, the less than 1 and the 1 to 4, there is more streptococcal disease. And you see the same in the 60 plus, so the older. And what you have within each age category is a bar for every year from 2009 to 2019. Again, we always stop pre-pandemic because things kind of got wonky in the pandemic time. So this is giving us an estimate of what was happening. And so what you see is in the younger kids, the incidence actually dropped quite importantly. This is after introduction of adjuvanted vaccines over that 10-year span. So we've made progress in kids, but what you see in the older, the 60 plus, which is actually the group we worry more about, is that it's flat. So we haven't had the same progress. And I think a big part of the reason for this is that we haven't had the same success in getting folks in that older group vaccinated. And I'll show those data in a minute. But this is to say we haven't made the same progress in the older group as we have in kids. Now, the reason we worry about this infection is that if you're hospitalized with pneumonia, it's not just the lungs. We see after that hospitalization, a functional decline. We see a 2.5-fold increased risk in developing moderate to severe cognitive impairment. Again, things outside of the lungs. And if you look at the percent of people who had CAP, which is community-acquired pneumonia, who had cognitive impairment lasting a year or more, 25% had moderate to severe, and 33% had mild. So we're talking about more than half the people for a year or more after a pneumonia having some type of cognitive problem, some type of problem with their mental functioning. So this is really important in terms of consequences. In terms of the risk factors, it's going to be, as I said, it's very similar across all of these pathogens. You have people who have normal immune system, but chronic diseases like heart disease, lung disease, including asthma. And then people who have a weak immune system due to things like HIV or organ transplant, et cetera. You have external factors like socioeconomic factors. People who are marginalized in lower income neighborhoods tend to do worse with this bacterial infection. Behavioral things like smoking, alcohol, those are risk factors for it. And age 65 plus, as we talked about, is a risk factor as well. In terms of asthma, the story around asthma and risk for invasive pneumococcal disease, I'd say that there have been many papers, but I'd say this is probably the most important kind of seminal study published now almost 20 years ago in the New England Journal. And what they did show in 2005 was that asthma is an independent risk factor for invasive pneumococcal disease. This is more severe type of pneumococcal disease. And that risk is 2.5 times higher in people with asthma than people without asthma in the population. So there is an important increased risk. Now, the asthma as a risk factor did not make its way into the NACI recommendations until all the way in 2014. So it took almost 10 years after the seminal paper, but it is there now. And so what do those recommendations look like for this vaccine? If you're 65 and over, it's recommended for everyone, whether you're healthy, whether you have a chronic disease or immunocompromising condition. It partly depends if you've had a vaccine for pneumococcal disease before and which one you've had and how long ago. So this will be a little bit different for everybody out there. If you're naive, you haven't had a vaccine, you just get the latest one. So I'll put up that part of the slide in a minute. Or if you're 5 years from your PPSV, okay, so your last polysaccharide conjugate vaccine, or 1 year from your PCV13, which is the one that many people would have had last year or in the last couple of years. If you are 50 to 64, it is based on your risk. So it is recommended for people with chronic conditions at risk, and many conditions, but I'm only showing you the chronic lung disease. And as I mentioned, it now includes asthma. They specify asthma requiring medical care in the prior 12 months. So we're talking about people who have relatively active asthma, who are on meds for asthma, not people who had, for example, a history of childhood asthma, but somebody whose asthma is still an issue for them. It is recommended down to the 50-year-old age. Once you're below that, for adults between 18 and 49, the recommendation is only for people with immunocompromising conditions. So these are really conditions like organ transplantation or people who have innately weak immune systems due to various conditions who really are susceptible to more severe infection. So for the category for people with asthma, it's really if you're 50 plus that you would merit it. And what is recommended now is what's called PCV 20. So pneumococcal conjugate vaccine 20. And that's a strong recommendation. And that's the latest version of this. Already, there is actually PCV 21. So it's been approved by Health Canada, but it hasn't been yet taken up by the provinces, but you're soon going to start hearing about 21. So we keep, graduating to more, and the 20 is referring to how many different subtypes are covered or are protected against in the vaccine. So we're soon getting to 21. There is a discretionary recommendation. Another option you could do is to take the PCV 15, followed about 8 weeks later by the PPSV 23. but the strong recommendation is to get the PCV20. So that's the one most people are going to get in most provinces. And the benefits really come from data we have from the prior set of vaccines. So, in the world of vaccines, there's often a lot of movement and change and improvement. And as you improve, you don't always have right away the large data sets from the large trials that are going to tell you about effectiveness. So you do smaller studies to tell you about safety, and you get a signal on effectiveness. And the way you do that is you try to see if the immune response, if the antibodies made by the body are comparable in level to what you had from the prior type of vaccine. So what we use is the data from PCV13 and PPSV23, which have been around for about 3 years now, to estimate the effectiveness of the newer ones, the PCV15 and PCV20. And what we know from PCV13 is that we had a massive trial in the Netherlands over 5 years, 85,000 people. It was 46% effective against pneumococcal pneumonia, 75% protective against invasive pneumococcal disease where the bacteria gets into the bloodstream. So this is a strong vaccine. This is a very protective vaccine. And as I mentioned, we know that the antibody levels in response to these newer vaccines are similar to the antibody levels you get compared to the prior vaccines. And the studies show us that these vaccines, these newer versions, are also safe. In terms of that safety, what happens? Well, what can happen? So you have local reactions and systemic, and it's the same stuff. It's pain in the injection site, a little bit of redness, a little bit of bumpiness. It's very similar, again, to the prior vaccines, and no serious vaccine-related adverse events have been reported with the new vaccines. The severity and frequency of those local reactions are very similar between the new and the old. Usually it's resolved within 10 days of getting the vaccine. For both vaccines, pain at the injection site is the most common. I think that's the case with almost all vaccines. And it's very similar. Just about 50 to 60% of people will get some pain at the injection site. And PCV20, which is the new one, was well tolerated in that older group as well of 60 to 64, again, with the similar safety profile to what we saw for PCV13 in prior years and in very large studies. So we have a good vaccine, we know it's safe, we know it's effective, but we're not getting there in terms of uptake. And these are some data from Canada in the last several years looking at vaccine uptake. So what you see here on the left side is for infants and children, our national goal is 95% or so, and you see that we're actually not bad. We're at 81% there in the yellow, and the blue and the dark blue there, that's just breaking down by sex. But the overall is 81%. When you look in the middle, adults 18 to 64 with underlying conditions, and that would include patients with asthma, our goal is 80%, but our uptake is only 26%. And when you look at seniors 65 plus, we really should all be getting it. If you have a goal of 80%, we're only hitting 55%. So this is partly to explain a slide I showed earlier where we're not making progress yet in terms of incidence of pneumococcal disease in the older population as much as we are with the younger population. And that has to do with the fact that we have better vaccine penetration in those younger kids than we do in the older and in the immunocompromised or folks with chronic conditions. So the summary, it's a common problem. It varies, but it affects different groups in different ways. But one of the groups that's susceptible is asthma. So it includes patients who suffer from asthma. It's not just the lungs. We also have complications and long-term side effects that go outside of the lungs, like cognitive issues. We have excellent vaccines that minimize disease, minimize severity of that disease and hospitalization. Given that our population is aging, and given that we have a larger and larger population of people with chronic diseases, an at-risk population, particularly for this vaccine, and it is the case for all the vaccines we'll talk about today, but particularly for this one, we are under-immunized. And so there is work to be done. Let's shift gears and talk about COVID-19. So COVID-19 is not very much in the news cycle anymore. We kind of have a lot of pandemic fatigue, so I understand why that is. But another reason we're not talking about it a lot or hearing about it a lot is that we don't have a lot of data on it anymore. So this is a screen grab from the Health Canada, Public Health Agency of Canada website, and it's talking about deaths. And you can see that for most provinces, there's an NA there. And the reason for that is that most provinces are not reporting data. And now, because of that, the federal government is not reporting. So you can see the quote there at the bottom, as of October 4th, this webpage will no longer be updated. So we will no longer have any death data. How about cases? Well, unfortunately, cases also are no longer reported. And when we had the data, We only had central lab data, which was obviously a vast underestimation because all of us were testing at home and not reporting those centrally. So no death data, no case data. What about hospitalizations? The hospitalization data at the federal level was last updated in July. So we will not have hospitalization data either. When we did have mostly provincial level hospitalization data, we didn't usually have a breakdown sort of separating people who were hospitalized for their COVID infection, whereas people who were tested on arrival and happened to have COVID but were being hospitalized for something else. So already those data were tricky, but now we don't have them at all. And in terms of deaths, a reminder that they are still happening. Mostly the deaths that we are seeing are in older adults, and particularly in under-vaccinated. I won't say unvaccinated because there are not a lot of people who are completely unvaccinated left, but under-vaccinated meaning that they haven't gotten their appropriate booster recently. But unfortunately, as I said, those deaths are not consistently reported. What we do have, though, is what's called wastewater. And so for people who aren't familiar with it, this virus, like most viruses, is actually shed in the feces. Even if you don't have symptoms, if you have the infection, it will be shed in the feces, and we can then detect that in the sewage, in the wastewater, and that becomes an early warning that the virus is spreading in the community. We have a way to quantify that and understand what the community burden might be. So the Canadian data that we have covers about 30% of our population. Again, it's not a measure of how sick people are, their hospitalizations, their deaths. It's a measure of transmission and risk. So what you have here is, again, from the PHAC website, by province, they're talking about risk. The overall COVID activity in the country is moderate. It varies a little bit more in central Canada there. If you look on this website, they'll give you the same data based on wastewater for flu, and right now it's low, so flu's a little bit later, as we showed earlier on earlier slides, and it's moderate for RSV, which we'll get to. What are your risk factors for COVID-19? Lots of risk factors. We've talked lots and lots about this in terms of demographics, people who are older, people who are in nursing homes, long-term care, but also equity-deserving communities. So our First Nations groups, Métis, Inuit communities, racialized Canadians, all of these folks are at higher risk of getting the virus and getting sicker from the virus, and of course, a long list of medical conditions. And I'll circle chronic lung diseases because they're very explicit, and this is from the NACI, that risk factor is limited to people with bronchiectasis, COPD, ILD, or interstitial lung disease, pulmonary hypertension, pulmonary embolism. So you may be asking yourself, where is asthma on that list? And so the asthma and COVID story is an interesting one. So if you look at early on in the pandemic, we had several studies suggesting that there was an increased prevalence of asthma among people who had COVID, and particularly those who were hospitalized for COVID, suggesting that asthma was a risk factor for hospitalization. 3 studies here that suggested that. Later on, though, we had studies that showed there was actually a decreased prevalence, or the same as population prevalence, in people who are hospitalized with COVID. And so this was sort of the opposite thing. And so where did we land? This is the most recent review, and this has been reviewed many times as new data become available. This is actually a massive review. So 51 studies, and they looked at the risk with COVID if you have asthma versus if you don't have asthma. What they found, very interestingly, was the only significant difference between asthma and non-asthma people was the risk of getting COVID, and the risk was actually lower, statistically significantly lower in people who have asthma. Talk in a minute about why that might be. But none of the other stuff, hospitalization, being in the ICU, needing a ventilator, dying, none of those other things were higher risk in asthma. So really good data, very reassuring actually for me as a provider who takes care of patients with asthma, and for you out there who may have asthma, that if you have this virus, you don't have a higher chance of something bad happening, and you might even have a lower chance of catching this virus. Why? Well, we know that seasonal coronaviruses, like COVID, which is now a seasonal coronavirus, don't actually contribute to more hospitalizations from asthma exacerbations. It's not like RSV. It's not like the flu. We also know that inhaled corticosteroids, which many people with asthma are on, reduce inflammation in the lungs, and they may decrease the expression of a receptor called ACE2, which is actually a receptor that the virus uses to get into our cells. At the same time, ACE2 expression is natively lower in people with asthma, and especially with allergic asthma. So that might be something that actually protects folks with asthma from getting this virus. But there are good reasons to get vaccinated, and one of the very important reasons is long COVID. So 1 in 9 Canadians have experienced long COVID or long-term symptoms from COVID, lasting 3 months or more after the infection. And the more times you get COVID, the higher your chance of having long COVID. So you have a 40% risk after 3+ COVID infections, and many of us have had 3 or more COVID infections by now. What's really scary is that if you're hospitalized with COVID, you end up with cognitive defects. If you end up with long COVID, you end up with cognitive defects that are comparable to aging 20 years. So there's a massive impact in terms of long COVID, again, outside of the lungs. It mostly affects a little bit younger cohort. So here's a little bit different than everything else we've talked about, where the older are more susceptible. Younger people are more susceptible, and that's when they're at the peak of their lives. We unfortunately don't have great treatments for managing long COVID. You have to rest and ride it out, but the vast majority of people, if you are suffering from it out there, the vast majority of people will get better and will get over it. But the good news is that vaccines lower the risk of long COVID. And aside from having a less severe infection, another really good reason to get the COVID vaccine is because you don't want to get long COVID. Now, what are the NACI recommendations? They basically recommend that anyone 6 months plus who is at increased risk of infection or severe disease, and all those risk factors we talked about, should be vaccinated. They have a strong recommendation for those folks. Remember, asthma is not in that category for this particular virus. If you're 6 months plus and you're not at increased risk, it's a discretionary recommendation. Go ahead and get it, but it's not as strong because your risk of something bad happening if you get the virus is not as high. But generally speaking, it is still recommended. Importantly, with the new vaccine, so we had a new booster vaccine in 23-24, there were no new safety issues identified. People worry about myocarditis. That really is an old story now. Myocarditis, inflammation of the heart, was seen in young males with their second dose, particularly of the Moderna vaccine. We're just not seeing that with the newer booster doses now. Not a concern. Couple things I want to point out. People ask, how effective is this vaccine? First point, it's not going to be as effective as the data we had in 90+% effective when the pandemic started, because we were comparing vaccinated folks to folks with no immunity. Now we're comparing people who get the booster to people who didn't get the booster, and that is a population of folks who often have had prior doses and have had prior infections. So we're comparing boosted people to people with some immunity from prior infection, so we're not going to see that same level of benefit. But we're still seeing, as you see in this graph, benefit in the range of 35 to 60% protection. And it depends on the age. So you have 18+ on top here, 18 to 49. It's broken down 18 to 49 and 50+. But across those ages, similar protection. And each row here is how long after you got the vaccine you were still deriving that benefit or that protection. And this is showing that even up to 6 months after the vaccine, there is a benefit, there is a protective effect. And so those are your ranges of protection. Not dissimilar to what we talked about with ranges of protection for flu vaccine and pneumococcal vaccine. That's sort of where we landed with this vaccine now. One thing I do want to mention is that if you break it down, and these are data from last year's booster, so this time last year, if you got boosted, what was your protection? Well, the protection was in that 55% range from XBB lineages. And this is important because that booster was designed for XBB.1.5, that specific variant. Sometime later, the virus evolved into what we call the JN lineages. So this is the next iteration of the virus, all still descendants of what we call the Omicron variant. But we see that there was a bit of a drop-off in protection against the JN lineages. And this is a reflection of the fact that as the virus changes, the vaccines need to be updated. And so what you have here is if you compare the JN to the XBB, in the middle, you see that 31 of their mutations overlap, but on either side, you've got 29 in JN1 and 11 in XBB that don't overlap. And so there's a difference there of 40 mutations. That tells you why the booster that was designed for XBB was not as protective against JN1. Now, what we have now is something completely different, and that's called KP3. Now, again, it's a descendant of JN1, but it has evolved. How does that compare to what we had previously? Well, here you have those same overlap graphs. The one I'll point out to you that's the most relevant is this one. And the reason for that is that the latest booster, the one you're going to get this year, or you may have already gotten, targets KP2. And what we have in the environment now is KP3 because the virus changes very quickly. But the good news, as you see there, is that they're very similar. They have a very similar pattern. They have 62 mutations overlapping, only 2 mutations that don't overlap. which suggests that if you get your booster this year, you're going to be very well protected against what's around now and what's going to be around for the foreseeable future. And that's the one we care most about. I always bring the cell phone analogy here because, you may have had a vaccine in the past. You may have had a booster last year. So you got some protection. You got a decent phone. You got an iPhone X here. But what you want is the latest and greatest. You want the iPhone 16 with AI capability. And if you haven't had a vaccine dose since your initial series and booster, then we really need to talk. But we do have a problem with COVID vaccine booster uptake. These are the uptake numbers in various provinces for the latest booster from last year, a year ago. About 18%, varies by province. But interestingly, it's quite a bit lower than what we have with the flu. And I think this is partly because of a lot of the misinformation that has come out about COVID and the fact that we're not talking about COVID as much, even though it's a very important virus affecting our population. But you see that for adult flu vaccination, although still not where we want it to be, it's in that 40% range compared to less than half of that for vaccination for COVID. In terms of safety, very safe vaccine. The side effects are mostly local, like pain, redness, swelling. We know about that. People can get a little bit of aches and body aches, headaches, joint pains. No increase in any of these things with the newer booster doses. Let's talk a little bit about some of the myths. People say it's not effective anymore. It's not an efficacious vaccine. Well, we know these vaccines have prevented millions of deaths and hospitalizations. As I said, the virus is always changing, so the vaccine needs to constantly change, which is why you need that booster. And again, last year's booster dose, I showed you those data, kept people out of hospital. Is it safe? Well, you're not going to have data on any other intervention created by human beings more than you have on this. 13 billion doses administered. It's been studied to death. Well, we talked about the side effects. They're mild. I mentioned myocarditis and pericarditis. It's just not being seen now with the newer booster doses. There really are no new safety concerns, and we know that these vaccines are safe. People say, I don't need the new vaccine. And people forget, every week, I see people hospitalized for this in our hospital. We see people who are older, who have weaker immune systems, die of COVID disease, and the virus keeps changing, and therefore we need to keep up with it. And don't forget the long-term conditions. I'll remind you that even if you're not worried about how sick you might get, do worry about things like long COVID. Last one is RSV, respiratory syncytial virus. People had not heard of this before the pandemic, but in the pandemic, we started talking about the big three and the triple-demic or tridemic. It's kind of number 3. After COVID and the seasonal flu, it's number 3. It's seen around the same time between October and May, particularly Jan, Feb. Transmission is very similar. It's actually more contagious than the flu. It's ubiquitous. So all kids have had this at least once by the age of 2. It's the most common cause of a lower respiratory tract infection in kids under 1. It can cause pneumonia, bronchiolitis, or inflammation of the airways, wheezing, which of course is similar to asthma, and apnea, or episodes where kids stop breathing. Can be very scary. It's actually the second most common cause of death in infants around the world after malaria, second only to malaria. So very important virus in children. And you see that here in the less than 1 on the left, but you start to see an increase again in the 65 plus and the 85 plus. And so the question you may be asking is, if you've already had it as a kid, why do you keep getting it? We do keep getting RSV, and a few different reasons. One is that there are different serotypes or subtypes. You might have had one subtype, but you're still susceptible to another. Also, there's this concept of waning immunity. We talked about the fact that our immune system does weaken over time. And so although adult infections tend to be milder because we have some of that immunity, once you hit 50 plus, your immunity starts weakening to the point where you can start getting more important RSV infections again. And although infections are less common than they are in children, people who are 65 plus have a chance of dying from this virus that is 6 times higher than kids under 1. And I'll show you what that looks like. This is a pie chart of the proportion by age of people who are hospitalized with RSV. So what you see in gray there is that 70% of people who are hospitalized are under 5 years old. However, their chance of dying if they're in hospital is 1 in 1,000. On the other hand, this graph shows the proportion of people dying from RSV in hospital. In the orange there, the 85% of deaths are in people 65 plus. They have a 1 in 9 chance of dying if they're hospitalized with RSV. So the story here is that you see a lot more infections and even hospitalizations in the young, but you see a lot more deaths in the older. population. In terms of risks, like most of these conditions, the more chronic diseases you have, the worse. And each of these chronic diseases that you see here confers increased risk, and that includes asthma. So less than COPD, but an increased risk in the range of 2.5 to 3.5 fold for having more severe RSV disease compared to people who don't have asthma. So asthma is a risk factor, just like it is for more severe flu. The good news is that in the last few years, we have 2 new vaccines for RSV. This has been a scientific breakthrough because they tried for years to get a vaccine. One is called Arexvy, one is called Abrisvo. They're very similar in that they are both what we call recombinant protein vaccines. So they use what's called the pre-fusion form of the F protein. So this virus has the F protein, which it uses to get into our cells. Basically, the vaccine is injecting a form of that protein. Your body sees it. It forms antibodies to it. And so your body is ready when the virus does come to attach to that fusion protein and protect it from entering our cells and protect it from fusing onto our cells. So very similar vaccines, and as I'll show you in a minute, very similar effectiveness. What the NACI recommends, although the trials, as I'll show you, show benefit in anyone 60 plus, the NACI has been more conservative, and they said, we're going to recommend this as a strong recommendation for anyone who's 75 and older, particularly if you have any of the conditions that weaken your system, but anyone 75 and older. That includes all of these conditions, and that, of course, includes asthma, but really it's an age-based cutoff. If you're 60 and older, they also strongly recommend it if you're in a nursing home or a chronic care facility, and the reason for that is that, again, those populations have been shown to have a higher risk of complications, just like we talked about with pneumococcal disease and with the flu. The NACI also mentions as a discretionary recommendation that if you're between 60 and 74, you can get it. We know that the studies will show benefit, but the benefit is not as strong as it is for the people with the truly weaker immune systems who are 75 plus. So that's where it becomes a conversation with your provider. In terms of efficacy, these are very effective vaccines. So the first one I'll talk to you about is a study that showed the efficacy being 67% for preventing disease with 2 symptoms or more, and 86% for disease with 3 symptoms or more. Also very safe. You see very low side effects here in the range of 5 to 10% for things like pain, redness, swelling, very similar to other vaccines. This is the other study that looked at the Arexvy vaccine. Very similar, 83% effective at preventing, a little bit different definition of disease, but 83% effective at preventing symptomatic disease, basically, and also very safe. So local adverse events like pain, a little bit more common, but redness and swelling, so mild things that go away quickly. The key points there, RSV is an exceptionally common infection, can impact people across the age spectrum, but also people with asthma. Older adults have a higher risk of dying when they're hospitalized from this. We have now data from 3 years. So the vaccine hasn't been available commercially for 3 years, but the trial data, people in the trial are now being followed for 3 years out. And the manufacturers have told us that, at least for one of these vaccines, there's still about a 50% protection into the 3rd season. So this is not something you're going to need every year. Probably every 2 to 3 or more years, you'll need a booster of this, but there's protection for several years. So it's a good investment to get this vaccine. And again, the adverse events or the side effects are very similar to other vaccines. So here's my summary. Getting a vaccine is a function of age, chronic conditions, and when you got your last vaccine. If you're 65 plus, it's easy. You're going to qualify for the flu, the pneumococcal, and the COVID. But particularly in RSV, it's a little bit older at 75. If you're 65, if you're under 65, if you have asthma, you're going to qualify for the influenza. For pneumococcal, it's if you're 50 plus and asthma. COVID-19 is a plus or minus because asthma is not really considered a risk factor for more severe COVID. So it's a decision you make. I do recommend it. And for RSV, it's for people between 60 to 74. Again, it's a plus or minus because according to the NACI, it's a discretionary recommendation in that group. And similarly, if you're healthy, very similar. You may or may not get the flu, but again, recommend as a discretionary. COVID-19, I should say, a flu is recommended for everyone as a strong. COVID-19 as a discretionary, and RSV between 60 to 74. It's again a discussion with your provider. Couple of practical points. Flu and COVID-19 can be given at the same time safely. That's been studied. I got mine together last year, so easy thing to do, just get it done in one shot. Flu and COVID can also be given at the same time as RSV. So either, obviously not all three, but you can give any of those two. We have less data on pneumococcal vaccine. There have been some studies suggesting it can be given at the same time as flu. There's some studies suggesting that it can actually be potentially given at the same time as the COVID vaccine. Generally speaking, I don't recommend it because there's never a rush with the pneumococcal vaccine, whereas with the more seasonally targeted vaccines, the other three, there's a bit more of a rush to get it done in the right season. So generally, we space the pneumococcal vaccine out. Coverage. Hard for me to speak to a national audience because it's different by province and it changes quickly. By and large, a flu vaccine will be universally covered. There are some provinces that only cover it for the higher risk patients. Every province will have one of these sort of stronger vaccines we talked about for 65 plus. Pneumococcal vaccine, we have the older ones, PCV13 and the polysaccharide 23. They are being replaced by 15 and 20. Most provinces will have the newer ones. COVID-19 is still pretty much in every province covered for free for anybody 6 months plus. And RSV is a lot more restrictive than any of the other vaccines in terms of coverage, perhaps because it's newer, and I do think that's going to change. We have more and more studies in susceptible populations, including asthma, that are coming out, and I think the age band will come down for that at NACI level, and hopefully in terms of provincial coverage. But for now, it's really limited to long-term care and nursing home residents in most provinces, and people do have to pay out of pocket in that $250 to $300 range to get that vaccine. A quick note I want to make about what I call risky times ahead because of this man, RFK Jr., who is an environmental lawyer with no medical or scientific training, but is about to get a very important bully pulpit. Trump has called him his new health czar. Whether he's going to be the head of the FDA or Secretary of Health and Human Services or what other role, we don't know, but he is going to have a lot of influence, and you're going to see him and hear from him a lot. The problem is that he is known to parrot misinformation, including misinformation that vaccines cause autism, something that's been debunked as fake science and fake data decades ago, but he still continues to talk about this. He's also prone to conspiracies. He has been heard saying that COVID-19 was intentionally targeted to attack Black and Caucasian people and to spare Jewish and Chinese people. So, racist tropes, not the kinds of things you expect to hear from somebody who's about to be in his position. But just a warning that you're going to hear a lot, and these types of views are going to become more prominent. So beware of where you get your information. And this is a slide I love putting up to talk about some of the tricks that people who spread misinformation and disinformation use. These are all true facts about water. Water can be chemically synthesized by burning rocket fuel. Overconsumption of water can cause excessive sweating, urination, and even death. Can you imagine? 100% of serial killers, rapists, and drug dealers have admitted to drinking water. Water is one of the primary ingredients in herbicides and pesticides. Can you imagine drinking this? It's the leading cause of drowning. How can we give our children water? It's a leading cause of drowning, and 100% of people exposed to water will die. I want to thank Asthma Canada. I want to thank Vivian Brown, Michael Boivin, and George Stanel, who helped me with these slides. And we're ready for a poll and ready for questions. Thank you.
Thank you so much, Dr. Gupta. You covered a lot of ground in the short period of time, so we really appreciate that. And certainly we are living in interesting and risky times, as you pointed out. Thanks for all of the great information that you provided today. We do have some poll questions that have been posted now. We ask folks, again, these are anonymous poll questions, and we ask you to take a moment to answer them if you can. In the meantime, while that's being posted, I will cover a few of the questions. We have a few minutes left here today, and there were a number of great questions submitted. So one of the themes that we're seeing in some of the questions is around the timing of the vaccines availability and why they couldn't be available sooner. So one of the questions was around, why are we not offering these in September instead of starting in mid-October into November? And do you have any information that you might be able to share about the timing and why it is the way it is?
Yeah, the timing can be frustrating. It does vary year to year. It's a procurement issue, like it was during COVID vaccine times. It's who gets what vaccine when, and it varies by province too in terms of how it's distributed. So it's procurement and distribution. That can be frustrating. But then the other thing I always remind people of is that, it takes a couple of weeks for the vaccine to work, but particularly for the flu, the protection does wane over time. So you don't want to get it too early. I tend to delay my flu shot because if you get it too early, you're not as well protected in the latter part of the flu season, and sort of by the time it's February, you don't have the same protection. So in some ways, it's not a bad thing that some of these vaccines are delayed a little bit. We don't want to see obviously too many delays, and folks who are immunocompromised want to get those vaccines earlier. But again, it comes down to procurement and distribution, and generally we get them when we need them.
Okay, thank you. I'll move to the next question quickly. You mentioned the risk of cognitive impairment. I think it was around pneumococcal infection. And the question was, is that due to oxygen saturation levels, or is there something behind that that you might be able to comment on?
Yeah, we don't really know. It's when you have chronic illness and we see cognitive impairment in older people who are hospitalized for almost any reason. In fact, it's probably a reflection of how the brain is responding to that inflammation around the body. So any major organ like the lungs being inflamed will cause inflammation in the whole body, and the brain responds to that. And sometimes the brain suffers some trauma from that inflammation. And so it's probably more inflammation than it is about oxygen levels.
Okay, thank you. We had a few questions about sort of the order of vaccines. So for example, someone says they're under 65, never been vaccinated. Would it be recommended to go straight to a PCV20 vaccine versus PCV15? Like, is there any sort of order of recommendation, or is it really around availability?
Yeah, so if you've never been vaccinated, go ahead and get your PCV20 is my recommendation to you. If you've had a vaccine before, consult with your health provider in terms of which vaccine and when. If it was a PCV13, you just need to wait a year. If you've had the polysaccharide, depending on when, which one you had and what combination, because some people have had the PPSV23 and the PCV13, others have had just the PPSV23. So for those ones, it's more a discussion with the provider. If you're sort of thinking about all four of these vaccines, what should you get? I would say get your COVID and flu now, and then in a couple of weeks, get your RSV or protected for this season, and then talk to your provider about the pneumococcal vaccine. It's less of an urgent matter, as I said, because it's not necessarily, that's a year-round risk as opposed to more so at this time.
Thank you. Question as well about, I know a lot of people have questions about the COVID vaccine, and one of them I think is particularly interesting around long COVID. So the question is, does the COVID vaccine now decrease the long COVID risks by decreasing infections in the first place, or does it actually decrease risk of long COVID even if you are infected?
Yeah, so the COVID vaccine is not very effective at decreasing infections anymore. That's the reality. We have a very, very transmissible virus now. What these vaccines mostly are doing is preventing the severity of infections. We know that the severity of infection is correlated with the chance of long COVID. So we think that that's the primary mechanism whereby vaccines are protecting against long COVID, is that they're protecting against you getting a severe enough case of COVID disease that you're at a high risk then of getting long COVID. So more so about severity than prevention of infection.
Also on COVID, in terms of timing, if someone had, this person says, I had COVID in August this year, should I get the vaccine now? Is there a certain sort of waiting period after infection that you would recommend?
Generally speaking, we would say you're good to wait 6 months. So, you're pretty good, but we do say that for those who have a weaker immune system or, immunocompromising conditions or on certain medications or have certain diseases, that they should get it sooner. And then that cutoff can be about 3 months for those folks. So depending on your personal medical situation, but for most people, they can wait about 6 months. Consider it like a booster in its own right, getting the infection.
Okay, thank you. Well, unfortunately, we're right up against the clock here and out of time. We do have other questions that we haven't been able to get to, but I think you've covered the vast majority of them, Dr. Gupta. So thank you again for your time. We really appreciate that. We would encourage people to reach out to Asthma Canada at any point if your questions weren't covered, or if you have additional questions. We have an asthma and allergy helpline that's available free of charge in both English and French to anyone across the country. So please reach out anytime. In the meantime, we appreciate your attendance. We again appreciate Dr. Gupta for your giving of your time and expertise. That was fantastic of you to do this for us today. As I mentioned earlier, we will be making this recording available, so we'd ask people to please share it. I've already, in the middle of this session, I texted my mother to let her know that I'd be sending her this recording. So we really do appreciate everyone's attendance, the support of the Public Health Agency of Canada for helping fund this type of work that we do. And again, please take a moment. If you could, give us your feedback. There's a link there on your screen. And please be in touch and keep an eye out for future webinars as well. And the last thing I'll just mention is that Asthma Canada does appreciate the support of all of our donors and supporters. So if you appreciate the work that we do, if you have the capacity to do so, we would ask you to consider potentially making a donation, as we are a registered charity. So we'll leave it at that. Again, thanks to everyone who joined us, and thank you again, Dr. Gupta, for a fantastic presentation.
Thank you. Be safe, be well, and get vaccinated.